Thank you. Thank you, Dr. Nuyana and Prof. Chan. Now let's move to the second talk. So the second speaker is our invited overseas speaker, is Prof. Arun Bansal. Prof. Arun is a professor of pediatric critical care at the Postgraduate Institute Medical Education and Research in India. This is the second best medical school in India. Is at Chandigarh, India. He did his MD degree at Chandigarh, and then further he received his MRCPCH in 2006, and was further trained in pediatric critical care from St. Mary Hospital, London in 2006. Arun has been keen in clinical work, academic and research, and he published more than 100 papers in the peer-reviewed journal, both nationally and internationally, and more than 50 chapters in books. His area of interest is in neurocritical care, pediatric ARDS, pediatric sepsis, and recently he also interested in MISC. He has been invited in various international conferences, including the upcoming annual scientific meeting of critical care in Malaysia, Shangri-La, tomorrow. So without further ado, we will let us welcome Prof. Arun to deliver his talk. Prof. Arun.
Thank you, Professor Chan, and good morning all. I would like to thank Dr. Chan, Dr. Shams, the University of Malaya, and all the Intensive Care Society from Malaysia for giving me an opportunity to be here. So it's really a great feeling. So I'll just start with my SharePoint talk. So can you see this, Dr. Chan?
Yes, I can see.
Okay, perfect. So I will be in the next 20-25 minutes. I'll be focusing on the how we had grown as a unit in the pediatric neurocritical care, especially focused for CNS infections, more so in a resource-limited setting, and how we had come to terms with our own queries and answers to that. Before that, I'd like to say that I come from India. That's in the north of India, Chandigarh. This is where we are located. This is my city. You are all welcome to visit, and we will be happy to host you. This is my institute, and on the right side is my department, the Advanced Pediatric Care Center. So I have nothing to declare or no conflict of interest. So I would like to give an overview of our emergency department. That what do we see? This was one of our papers published on the referrals to pediatric emergency department in our hospital for the quality improvement studies. So we drain almost whole of the North India in our hospital. So the kids come, all the patients come from all over. And majority of our patients were referred patients. So 90% of them were referred, and they were from all over the North India, coming from far off places. And majority, in 38 or 40% of the kids were with the CNS problems, followed by the respiratory problems. And we have been seeing thousands of patients per year, and this has been gradually increasing over the last decade or so. This is a typical emergency, which we see. It's a 22-bedded emergency, and we have almost 3 to 4 times it's overloaded, and so each bed maybe has more than 4 or 5 patients sometimes. So that's what our normal load is. And similarly, we have a 16-bedded PICU, and we see almost 1,000 patients per year in our ICU. We have in the ICU both the non-invasive and invasive hemodynamic, respiratory, neurologic, and renal monitoring facilities. We do the peritoneal dialysis, hemodialysis, SLED, CRRT, and ECMOs. We also have a good lab backup of bedside ultrasound, ABG support. We have the good radiology support, and the 24 hours blood lab support is also available. Personnel wise, we have 4 faculty members who are managing the ICU and emergency. We have 2 fellows each on day and night shift. We have 5 MD fellows, the residents each in the day and night, and our ventilation beds nurse patient ratio is 1:2. Though it's not the ideal, but that's I think we are still fortunate in our country to have this because most of the centers don't even have that, and there are 2 lab technicians. So with this background, I would like to give you the outline of the talk that based on these 4 or 5 parameters. So we'll start with what's the burden of the CNS infections in India is. This was one of our study which we did publish few years back on the kind of patients we see with non-traumatic coma in our institute, and CNS infections constituted 60% of our load of CNS non-traumatic coma. Very common, including encephalitis, bacterial meningitis, tubercular meningitis. Then we again did another study which to look at the in the acute symptomatic seizure children, what was their clinical profile and outcome. So again, in this, CNS infections was the most common cause of the acute symptomatic seizures. And the common CNS infections included meningitis, encephalitis, malaria, and abscess. And predictors of poor outcome at discharge included the underlying CNS infections, which was the most common reason of the poor outcome at discharge in children who present with acute symptomatic seizures. Then we again published one of our own data on this, the tropical fevers, what are the kind of pattern. This was a multi-centric study from all over India, multiple centers were there. And the common infections which we see are the dengue, scrub typhus, and meningitis and encephalitis. Again, very common infections. I think it's all in the this part of the world is very common. And this is the monthly distribution and how it varies. Mainly in the monsoon seasons, we have more of the load of these patients. And encephalopathy was seen in almost 30% of the cases of children with the tropical infection. So it's not uncommon for these like dengue, scrub to present with encephalopathy or malaria, apart from meningitis and encephalitis. We just heard a beautiful talk on leptospirosis, but we also do see leptospirosis in our part of the country. This is again like the pictures we have shown. The load in our unit also varies and it peaks mainly during the monsoon season month-wise. So that's the kind of load which we have in our part of the country. And how do they stress the ICU care in when we have such kind of patients come in? This is what we've seen, that when these patients come to an emergency ICU, so they mainly require present with airway instability, respiratory depression, and almost half of the patient at raised ICP or refractory status at admission along with shock. So they are mainly the viruses are the most common causes, and morbidity and mortality are very high in virus compared to the non-viral patients, and HSV1 is the most common cause of encephalitis. And they require assisted ventilation. They also associated with prolonged hospital stay and increased mortality. And raised ICP is very common in these children, and there's one of the factors associated with death and also the need for assisted ventilation. So they burden quite a lot of your ICU workforce, their beds, the strength, and all this. So how does the pediatric critical care cope up in such a resource limited care setting, especially when you have limited PICU beds, you don't have enough ventilators for all the raised ICP patients, you don't have the trained manpower for these kind of people. So these are the common challenges which we face, especially the personnel, equipment, and healthcare system. And this can all lead to suboptimal care and increase in the mortality of these kind of cases. Moreover, the true burden may not be whatever I have presented. The data may not be the true picture, because many of these patients are not reported or get into the mainstream and are not underreported. So these can lead to both the local and the global underreporting or appreciation of these patients. And there are significant staffing challenges exist in our part of the world. Majority, especially with the nursing, we have the staff, and if they get trained, they tend to move to the developed countries or the Western world. Similarly, there is a lack of trained fellows or the pediatric intensivists who can manage these patients and take care of their acute care needs. Then we also have less number of support from the allied professionals like the respiratory therapists, dietitians, pharmacists, or physiotherapists. So they are not always available bedside or not available in most of the centers. Most of the nursing people does not have the critical care training, and they don't know how to handle the ventilators or the dialysis machines or the patients with raised ICP. And there are very few formal training programs for physicians or mid-level providers in pediatric critical care field. So these are the common challenges or the problems which we face. In the pediatric neurocritical care, we usually follow the Western guidelines, and they are mainly for the traumatic brain injury patients. And for the non-traumatic patients, we just extrapolate these guidelines from them. And even in pediatric TBI, these guidelines are extrapolated from the adult TBI guidelines, even in the Western world. So as these guidelines or the picture was evolving over the world, in India, we in early 90s, we started the pediatric critical care services. Then in 93, the first Indian Society of Critical Care Medicine was established. Then in 1998, we established the Pediatric Intensive Care Chapter. So it's almost now 25th year, which is going to be next year. We will be celebrating that. Then in 2000, we established the pediatric section of the Indian Society, which is the Adult Society of Critical Care Medicine. And in early 2000s, there was the significant growth in the corporate hospitals in India. And in 2010, we had a lot of literature coming up in this late second decade of this 20th century. This was in sync with what the Western world of the global community was doing. In 2000, the first edition of guidelines for the medical management of severe TBI for infants, children, and adolescents came up. Then in 2009, the Brain Trauma Foundation formed an expert panel group to generate the new recommendations. Then in the second decade of this century, a lot of RCTs on many of these things have come up, but they're mainly focused for the pediatric TBI patients. So what we with this background, we can say that the neurocritical care and the multimodal neuromonitoring was a felt need. And our unit got its first ICP monitor in the year 2007. And we started monitoring the ICP from then. Our first critical care fellowship started in 2009. And we have been now slowly and steadily trying to catch up with the developed world of the global community. And hopefully we will come to somewhere in the match up to them in the near future. With this came up the numerous questions that what are our local problems, because many of the answers were not coming from the global guidelines. Our first question was the CPP targeted therapy in acute CNS infection, is it feasible or not? So we did this observational feasible study and published in Journal of Child Neurology whether the CPP targeted approach in children with infection was feasible or not. We targeted two pressures, that more than 70 mm in 2 years old and lower than 16 less than 2 years. And we targeted CPP by using the boluses, vasopressors, and mannitol. And we found that children who survived and with no sequelae were better in the high CPP group than versus those who died and they had a low cerebral perfusion pressure. And a targeted CPP was achieved in 6 patients, and all patients who had a CPP less than 50 had died of intractable raised ICP, versus only 3 out of the 16 patients who had a CPP more than 50. So we concluded that to achieve a CPP more than 50 was feasible by increasing the blood pressure in the first 24 hours. Then the next question came was that who will insert an ICP catheter, whether we need to call the neurosurgeons or the intensivist. We usually do at bedside ourselves, our pediatric fellows put in an ICP catheter, and we published our experience in PCCM of our 10-year experience on our placing the ICP catheters. And we have been regularly placing since 2004 and 5 the ICP catheters, and we have placed now more than 500 patients. This was a data of around 260 patients in which ICP catheter was placed. Intraparenchymal is the predominant one, and we hardly had any complications associated with these patients. And the median duration of ICP monitoring, which we saw, was around 96 hours, and the overall mortality was around 30%. But what we concluded that was that pediatric intensivists can themselves perform the burr holes at bedside for establishing the ICP monitoring, especially the intraparenchymal ones. We don't have much experience on the intraventricular ones. Then another question came up in your mind was whether the CPP or the ICP targeted therapy in CNS infection, which is better, especially with respect to mortality. We did an RCT on this and published in Critical Care Medicine of 110 children with CNS infection and having raised ICP and GCS less than or equal to 8, randomized them equally into the ICP targeted therapy versus the CPP targeted therapy. Majority of them were the viral ASA or acute meningitis group. And we had what we saw that in the CPP targeted group had more chances of survival versus the ICP targeted, and number of patients who had a coma of less than 8 was also less in the CPP group than in the ICP group. And the number of patients, the hospital length of stay was also less in the CPP group than in the ICP targeted therapy group. So what we concluded that we found was that the median duration of coma was lower by 2 days in the CPP group. PICU stay was lower, duration of mechanical ventilation was lower, and the children with severe neuro disability at 90 days was lower in the CPP group as compared to the ICP group. The next question came up in our mind was whether mannitol or hypertonic saline as an osmotherapy, which is better. This is another paper of an RCT which we published in 2020 in the PCCM journal, and we saw that mean ICP was lower in the hypertonic saline group, and mean CPP was better over 72 hours in the hypertonic saline group, and even the median GCS at 72 hours was better in the hypertonic saline group. So we found that a 3% hypertonic saline was superior to 20% mannitol in reducing the raised ICP in children with acute CNS infections. Then we also wanted to know whether which sedation is better, what to give. So another RCT which is ongoing is the comparison of Midazolam, Fentanyl versus Midaz and Ketamine in pediatric raised ICP due to acute CNS infections. We presented our midterm data in the SCCM meeting at USA in last year, and this paper won the bronze medal in that category, and we are comparing these two, and hopefully the results will be out soon. Then what is the role of decompressive craniectomy in refractory raised ICP? That was the another question. If they have refractory or intractable raised ICP, this was the non-traumatic raised ICP cases. We presented our retrospective data, and we found that the spontaneous intracranial bleed was the most common etiology. And timely decompression may be beneficial in children with non-traumatic ICH due to focal pathology. We found a mortality benefit was seen, but unfortunately, half of them still had poor outcome at 1 year. And anisocoria at admission was the only independent predictor of poor outcome at 6 months. But we need more studies, and also we are sure about the timing of the decompression in non-traumatic ICH. So we need more data on this. Next question came up: if you don't have the invasive monitoring, can non-invasive monitoring methods help in children? So, what is the role of NIRS in non-traumatic coma? This is again an unpublished data from our unit. We found that regional saturation strongly it has a direct correlation with ICP and an inverse correlation with the CPP. So we found that when the regional saturation is less than 50%, it is associated with raised ICP. And if the saturation is good, regional saturation is good, then it's associated with more increase in the cerebral perfusion pressures. So we did this study and it is still to be published. We are in the process of that. So what we concluded that from this study was that NIRS can be a non-invasive monitoring tool in children with raised ICP when invasive monitoring is not feasible. Can ONSD and optic nerve sheath diameter and the transcranial Doppler, the TCD, be beneficial in non-traumatic coma? So we did an observational study of the evaluation of optic nerve sheath diameter and transcranial Doppler as a non-invasive tool to detect raised ICP and publish in PCCM. We found that a mean ONSD of 5.7 was there in the all the children with raised ICP and CNS infections, and compared to the other two control groups. So on this ROC curve, we found that the optic nerve sheath diameter of 4 millimeter had 98% sensitivity for raised ICP, and it was quite specific also. And this is what we found. So this can be another very good tool to monitor the raised ICP, especially non-invasive optic nerve sheath diameter. We did not find good correlation with the transcranial Doppler with the raised ICP in CNS infections. So this was our algorithm, which we published, our unit's algorithm on the management and stepwise management of raised ICP. And all this has been possible, which was started in early 2000, the neurocritical care monitoring by our mentor, Dr. Sudeep Singhi, who was a founder of the Pediatric Intensive Care Society in India. So multi-modal monitoring in our PICU includes ICP monitoring, NIRS, continuous EEG, ONSD, along with the other neuroradiology and other support. This is a typical raised ICP patient, which we manage in our unit. So just to summarize, acute CNS infections are common and are associated with significant mortality and morbidity. They have the significant ICU needs, especially the raised ICP and seizures. If they are associated, they take up a lot of resources. In resource limited setting, the management of these patients can be very challenging. And it's difficult to extrapolate the global guidelines locally because the patient profile and other resources do not match with whatever the guidelines say. So we need to create the local guidelines based on our the questions or the data which we have. So I would like to end that the both can go hand in hand. We can learn from the global guidelines and tailor them to our local needs. So it is the local is the is the need of the hour. So I'd like to thank from our team, and I would like to acknowledge my faculty colleagues who had helped me in this growth of our chapter and our unit in of this. So thank you so much.
Thank you, Prof. Arun, for the excellent talk. I would like to congratulate you for the achievement that you all have made in this neurocritical area. I would like to ask, particularly in the invasive ICP monitor, I'm very interested and impressed that how our pediatric intensivists can actually carry out this task by inserting the ICP board. Could you share more with us about this?
Yes. So thank you, Dr. Cheng. I think that's a very common question which is asked to us by everybody, because people are scared that how can an intensivist put in an catheter in. So our neurosurgery colleagues were very kind in early 2005-06 when we started this program. So we got the training under their support and guidance. So once it was there, we gradually started building up. So you need to work with them, learn from them, and then gradually you'll start gaining confidence. So now our own fellows are confident enough and have been placing it on the bedside without any support from the neurosurgeons. And we hardly had any complications associated with the placement. So they're very confident. So it's basically with the starting as a multi-collaborative team and then gradually learning and growing from there.
Excellent. Yeah. So we still need to work hand in hand with our surgeon and find out the agree indication to put in. I don't see any more further question from the chat box. Yeah. And I think we are in the common, we face the common challenges like you face as well. And we also deal with academic work, with clinical work, and as well as research. We had a lot more to learn from you. And today we just would like to thank you for this sharing. And we want to thanks to all participants for attending this session. Yeah, thank you, Prof. Arun.
Thank you. Thank you so much for the opportunity. Thank you.
Thanks.